Hello everyone, I am Valentina Gallusto. I am a cardiologist at the Fate Bene Fratelli Hospital in Milano, Italy. And a few years ago, I had the good opportunity to work 1 year in the cardiac imaging laboratory led by Dr. Arturo Evangelista. And the case I'm going to present now is one of the ones we had in my rotation at the Val de Hebron, and I hope you find it interesting. The patient was a 17-year-old man who had a motorcycle accident that resulted in a chest trauma with severe chest pain and marked hemodynamic instability, for which he was referred to the hospital. CT showed an image of pseudoneurism at the level of the aortic isthmus, which is a typical site of traumatic aortic injury, with signs of cottonous rupture, periaortic bleeding, and left pleural effusion. Endovascular treatment was urgently indicated. In the lower right image shows the pseudoneurism in the angiography performed during TEVAR. A 24mm stent was implanted, and the control carried out after TEVAR implantation confirmed that it was well placed and without any abnormality. This can also be seen in this reconstruction by left parasagittal projection. The patient remained completely asymptomatic and lived a normal life until 1 year after TEVAR implantation, when he presented with rapidly progressive resting breathlessness, abdominal pain, and left leg paresthesia, so he went to emergency department. In the emergency room, he was markedly hypertensive with a pressure of 220 and 120, a heart rhythm at 106 beats per minute, and to the X-ray of the thorax was compatible with pulmonary edema. It was indicated nitroprusside treatment, and a transesophageal echocardiography was indicated, which showed the presence of a subtotal thrombosis in the distal third of the stent. The proximal part of the stent was normal. For this reason, treatment with intravenous heparin was started, and after 24 hours, transesophageal echocardiography was repeated, which showed a mild decrease of the distal obstruction of the stent. However, the patient was still markedly hypertensive, and therefore surgical treatment was indicated with implantation of an extra anatomic bypass. You can see here the CT scan performed between the two transesophageal echocardiographic studies, which confirmed the diagnosis of subtotal stent thrombosis without signs of stent degeneration. In this reconstruction with full volume, the abrupt interruption of the descending aorta at the distal level of the stent is observed. In the surgery, an extra-anatomic bypass was implanted from the ascending aorta to the descending aorta above the celiac trunk. The patient's arterial pressure normalized and the pulmonary edema rapidly disappeared. In this CT control, the extra-anatomic bypass from the ascending aorta to the descending aorta is seen. Therefore, we present a subtotal stent thrombosis as an unusual complication of TEVAR. This complication may be created from minimal injury to the intima in the proximal or distal end of the stent at the time of implantation, which triggers a progressive thrombotic process. And this complication is more frequent in traumatic lesion of the aorta because probably the aorta in this injury is not dilated, and there is an oversizing of the stent. That is why it is very important to perform a control CT scan at 1 month and at 6 months. Cases with mild intrastent thrombosis can be treated by oral anticoagulation, but in cases with subtotal thrombosis of the stent with significant hemodynamic repercussion, treatment with open surgery is indicated. This is the publication in the European Journal of Cardiovascular Imaging, where the case was summarized. Many thanks to all of you, and many thanks to Arturo.